Okay, and welcome everyone to week 7. This is going to be the first of 2 sections on pulmonology, respiratory pathology. We're going to start out with a really quick review of pulmonary physiology. I think it's important to review that, as that will be helpful in not only understanding the pathophysiology, but also understanding resuscitation and also understanding a number of the drugs that I'm going to be going through in these next 2 weeks. Here's your reading assignment, so let's get to it. Here are some terms I would like you to be familiar with. When we talk about respiration, we're talking about what's going on at the cellular level. That's burning in glucose and oxygen through metabolic pathways to develop ATP. Ventilation is the movement of air in and out of the lungs. So when you're resuscitating an apneic individual, you want to be sure that you're doing appropriate ventilation, appropriate movement of air in and out. Diffusion is the transfer of oxygen and carbon dioxide across the alveolar membrane. O2 from the alveoli into blood, CO2 out of blood back into the alveoli to be exhaled off. Oxygenation is the binding of oxygen onto hemoglobin. We covered that. We'll do a little bit more of that in this unit. Transportation, the delivery of oxygen around the body. We talked about that, and we talked about red blood cells. And then obviously your respiratory rate is the number of times that you go through a respiratory cycle. Breathe in, breathe out, that's one cycle. How many times you do that per minute is obviously the respiratory rate. Here's a cadaver section showing you some anatomy. We talked about the thyroid gland already, so you see that wrapped around the trachea. You see the great vessels of the heart, the aorta and the pulmonary artery coming out of the heart. Heart surrounded by pericardium. We'll be looking at all that in a lot of detail in the cardiac units. For now, you can see the diaphragm, the major muscle of ventilation, separating the contents of the thorax from the abdomen, a right lung, a left lung, and then the covering of the lung, the pleura, and we're going to be talking about that covering in pathology of the pleura. If we take away the heart and take away some of the anterior portions of the lung, now you can see the lobes of the lung, right upper, right middle, and right lower, left upper and left lower. You can now see the bifurcation of the trachea into the right and the left mainstem bronchus. You can see the bifurcation of the pulmonary artery into the right and the left pulmonary arteries. SVC, superior vena cava, going into the right heart. The vagus nerve is important in innervating internal organs. And we're going to talk more about the vagus nerve when we get into cardiology and GI tract. The vagus nerve does not innervate the diaphragm. The vagus nerve is a cranial nerve. It's a 10th cranial nerve. The diaphragm is innervated by the phrenic nerve, and that comes from the cervical vertebrae, cervical 2, 3, and 4. On a chest x-ray then, you can see the larynx, the trachea, and the carina. You can see where the takeoff of the right and the left mainstem bronchus would be. You can see the diaphragm shadows, the stomach bubble underneath the left side of the diaphragm. Yellow lines showing you pulmonary vasculature. Blue lines, if you look really close, you kind of like pointing into a hollow region. Those are bronchial tubes kind of projecting out towards you, so you're actually looking into the lumen of the bronchial tubes. Remember, air looks black on an x-ray. If you look around, you can see other bronchial tubes in there as well. Chest x-ray versus a CT scan. Again, try to identify all those areas: the trachea, the carina, the bronchi, diaphragm, lobes of the lung. We'll get into all the cardiology stuff in a couple of weeks. Right now, let's just focus on the pulmonary anatomy. Upper respiratory system, now beginning from the nose down through the vocal cords. So everything above the vocal cords is the upper respiratory tract. Everything below the vocal cords, the lower respiratory tract. So you can see the nasal turbinates, the nasopharynx being continuous with the oropharynx. And then you can see how the oropharynx splits into the esophagus, which goes posterior, and the trachea, which goes anterior. Before we get into the trachea, we have that flap of tissue referred to as the epiglottis, which is going to protect and cover the airways so we don't swallow foods and liquids down into the respiratory tract. And then you can see the vocal cords housed there in the laryngeal cartilage. And then once we get through the vocal cords, then we are in the lumen of the trachea. And on the x-rays, x-ray on the left, CT scans in the middle, and on the right, you should also be able to identify those structures, particularly the nasopharynx, the oropharynx, the epiglottis, and the trachea. Be sure you can identify all those structures. Sinuses. We have a set of sinuses, hollow cavities in the facial and skull bones. Frontal sinuses above the eyes, ethmoid sinuses between, maxillary sinuses below. Another set of sinuses that we have below and behind the ears are the mastoid sinuses. Those are not pictured here. You should be able to identify frontals, ethmoids, and maxillaries on the cadaver section. And then on the x-rays and on the CT scans, be able to identify frontal, maxillaries, and ethmoids, and then look at that x-ray to the far right, and you can see kind of in that lighter green or aqua type color, you can see the mastoid air sinuses out laterally on the skull behind and below the ear. The nasopharynx, so the opening from your nares through your nose, the nasopharynx is anatomically different from the sinuses, and we're going to talk about the differences between rhinitis and sinusitis. Another reason why we want to differentiate rhinitis versus sinusitis is, let's look at babies here. And here we're looking at some x-rays of infant skulls, diagram and an actual infant skull. And one thing that you do not see on the infant are sinuses. As a pediatric physician, it drives me nuts to see people diagnosing sinusitis on infants, and infants, I'm talking about under 1 year of age. They don't have sinuses. They have a nasal airway, and you can see the nasal airway on the x-rays and on the skulls, but those are not sinuses. All right? Frontal sinuses start to develop around age 5 to 7. Your ethmoids and your maxillaries a little younger. Maybe by 2 to 3 years, you're starting to see ethmoids and maxillaries, but particularly frontal. Please do not diagnose frontal sinusitis in infants and very young children, because anatomically they're not there. So once again, when we get into inflammation and pathology, we are going to differentiate rhinitis versus sinusitis. Very important. Take a deep breath in, take a deep breath out. Do it again and keep going. So respiratory rate, as you all know, is one of the vital signs. The respiratory cycle is divided into an inspiratory and expiratory component. If you were to watch somebody breathe, you would see that the amount of time that we spend in inspiration is not completely equal to the amount of time spent in expiration. In fact, we spend a little bit more time in expiration. That's referred to as the inspiratory-expiratory ratio. It's typically 1 to 2. Why is that important? When you're resuscitating somebody, whether you're doing mouth-to-mouth, bag respiration, placing them on a ventilator, you want to be sure that you provide time to empty the lungs, to breathe out, right? Don't just ventilate, bag the hell out of somebody where you just keep pushing air in. You need to give them some time to exhale. So remember that normal physiologic inspiratory to expiratory ratio is about 1 to 2. And the number of cycles per minute equals your respiratory rate. And typically at rest, an adult should be breathing somewhere between 12 to 16 cycles per minute. Getting air in, getting air out. So how does that process happen? Atmospheric pressure is the pressure that we feel due to that column of air pressing down on us from our atmosphere. That varies depending on where we are. It's a little higher at sea level, a little lower up in the mountains. But in general, we're going to talk about atmospheric pressure as being about 760 millimeters of mercury. So inspiration is the result of making negative pressure inside our chest, and the negative pressure inside our chest then is going to, like a vacuum, draw air into our lungs. So how does that happen? When we breathe, we do two things. We contract the diaphragm. When we contract the diaphragm moves down, and we contract intercostal muscles between our lungs. When we contract intercostal muscles between our lungs, the chest cavity moves up and out. So what we're doing is we're expanding the chest cavity. As we expand the chest cavity, we generate negative inspiratory pressure inside the chest. This is usually referred to as PIP. That negative inspiratory pressure is going to act to draw air into lungs. All right? So we are self-ventilating due to the fact that we generate negative interthoracic pressure. Exhalation now at rest is a passive process. We do not need to contract any skeletal muscles. We need to contract the diaphragm and intercostals to take a breath in. Taking that breath, pushing that air out is a passive process, and it's done by the elastic recoil of the diaphragm and the chest wall. As the diaphragm recoils back upward, the chest recoils back inward. Pressure inside the chest now exceeds atmospheric pressure, and air flows out. And it's all about elastic recoil in compliance. Elastin and collagen proteins in the chest wall and the diaphragm allows that to happen. So again, at rest, we don't need to contract skeletal muscle. That can happen passively. So now, watch somebody, your kid, your husband, whoever, somebody around, just watch them breathe. Watch quiet inspiration, count the respiratory rate. And again, quiet inspiration primarily dependent on diaphragm, some intercostal muscles. quiet expiration due to elastic recoil. Now, let's stress your individual. You know what a burpee is, right? There's a diagram of a burpee. So get your whomever, get your significant other, your friend, your kid, get them doing burpees right now. Get them going. Get them going. Keep them going. And then what I want you to do is, as they're moving through that, I want you to watch them breathe, and I want you to particularly pay attention to all the additional muscles that they're calling into play to make that distressed inspiration and expiration occur. They're contracting their diaphragm harder. They're contracting their intercostal muscles harder. Now they are recruiting neck muscles to generate more negative interthoracic pressure, to get more ventilatory effort, more air flowing into the lungs. And then expiration now is no longer passive. They're actually using intercostals and abdominal muscles to contract the thorax and push that air out. Are they still doing burpees? Keep them going. Come on. And then watch them. And then just be sure that you've got a really good understanding of how the mechanics change between quiet at rest, inspiration, expiration, and then distressed breathing. And in this case, we're simulating distressed breathing via exercise. All right, give them a break. Go get them some water or something. Give them a break, and we'll go on studying. Hey, it's your birthday. You didn't know that. All right. Now, in front of you, you've got this massive cake loaded with candles. And what you want to do is you want to blow out all those candles just using one breath. So let's make that happen. I want you to take the deepest, most fullest inspiration that you can. Fill every single alveoli full of air. Keep sucking in the air until you can fit in no more. And then as fast and as hard as you can, blow that air out. Ready? Go. In. Keep inhaling in. Keep inhaling in. Get a little bit more in. And now out. Just inhale. Exhale out. Sorry. Exhale. Breathe it out. Breathe it out. Push it out. Everything. Push it all out. Did you blow out all the candles? I hope so. All right. Let's look at what you just did in terms of pulmonary function testing. At quiet inspiration and expiration, the amount of air that we're exchanging is referred to as our tidal volume. In a healthy, normal-sized adult, that's about 500 milliliters of air. In a child, that's about 7 milliliters per kilo of body weight. Okay, so obviously a baby doesn't breathe as much tidal volume as an adult, neither will a small child. Their tidal volumes are a little bit lower. When you took that total breath in, when you got in as much air as you possibly could, now you're going above your tidal volume and you're going into your inspiratory reserve volume. So if you add those two together, you've got your inspiratory capacity. All right? And then when you blew all that air out, when you blew out as much air as you possibly could, you went below your tidal volume and you kept blowing out. You hit your vital capacity. And just when you felt, that you've blown out those last molecules of air, you still have some air left in your lungs. That's referred to as the residual volume. So you never really fully deflate your lungs. And we're going to look at these different pulmonary function testing as we go through the different types of pathologies. I definitely want you to understand tidal volume, inspiratory capacity, vital capacity, and residual volume. And then be aware your tidal volume, and all your volumes by that matter, but particularly your tidal volume changes based on your size. And you have to account for that when you are resuscitating a large individual versus a small individual. You want to be sure that you're giving them appropriate amounts of tidal volume. All right, another important pulmonary function test is something called the FEV1, your forced expiratory volume in 1 second. So take a deep breath in and push out as much air as fast as you can in 1 second. That's referred to as your forced expiratory volume in 1 second, FEV1. That becomes an important measure when we start to talk about asthma and COPD. These handheld peak flow meters are approximating an individual's FEV1. Okay, minute ventilation. If you take your respiratory rate times your tidal volume, and again, we're just going to assume that your tidal volume is about 500 milliliters, multiply that together, and that gives you the total amount of air that you're exchanging in a minute. That's your minute ventilation. 500 times 12 is 6,000 ml, so about 6 liters of air. Your alveolar ventilation is the amount of air just going into your alveoli. And it's important to understand that we are only exchanging and diffusing gas in the alveoli. We do not exchange any air in the nasopharynx, oropharynx, larynx, trachea, or bronchial tubes. That's referred to as dead space. So when you take a breath in, you fill up that dead space, but that dead space is not doing you any good in terms of diffusion. In a healthy adult, about 150 milliliters of that tidal volume is dead space. 350 milliliters gets into your alveoli. So your alveolar ventilation is going to be less than your minute ventilation. So in this case now you take 350 times 12, and that gives you your alveolar ventilation, how much air you're exchanging within the alveoli. So which is better, the depth of your respirations or the number of breaths that you've taken? So if you're breathing your normal tidal volume 12 times per minute, your minute ventilation is 6 liters, but your alveolar ventilation is just over 4,000. Now what I want you to do is take shallow breaths, but breathe 40 times per minute. Try to do that. It's difficult. You might get a little dizzy, so be careful. You're still exchanging the same minute ventilation, but look at your alveolar ventilation. When you're taking those very shallow breaths, but very quickly, really all you're doing is filling up dead space. You're not getting much air down into your alveoli. As opposed to you take nice, deep, slow breaths, right? Double your tidal volume, but half your respiratory rate. And you can see that you keep the same minute ventilation, but now look what happens to your alveolar ventilation, right? So slow, deep breathing, rather than rapid, shallow breathing for the individual who's under the stress, whether that's anxiety, trying to catch their breath after doing burpees because you're a mean person and you made your loved one do a bunch of burpees, right? All right, so understand that concept between minute ventilation, anatomic dead space, and alveolar ventilation. Okay, our respiratory rate and how deep we breathe controls the amount of air getting to our alveoli. Another big determinant in terms of what controls the amount of air getting to our alveoli is the caliber or the size of the lumen in the bronchial tubes. So here's two hoses. If your house were on fire, which of those two hoses would you prefer to use? I hope if you like your house, you'd want to use the larger caliber lumen hose, the red fireman's hose there, because you're going to get more water flowing through. So it's the same thing here when you're breathing under duress, particularly when you're exercising and doing burpees. You want your bronchial tubes maximally dilated, increasing the size of the lumen so you get the maximal amount of air moving into the alveoli. The bronchial tubes are made up of both cartilage and smooth muscle. The cartilage, you have no control over the cartilage, but there is control over the muscle. When you constrict the smooth muscle, the lumen narrows. When you relax the smooth muscle, the lumen opens up. So we want bronchial relaxation, right? We want bronchial relaxation, opening up the bronchial tubes at times of exercise and at times of breathing distress. Another term that I should probably talk about is a conducting zone versus the diffusing zone. So again, there's the delineation at the black arrow. Everything above the black arrow is conducting zone. That's anatomic dead space. That's air which is in those lumens, but it's not diffusing. The only air that we diffuse gases is occurring in the diffusing zone, and that's our alveoli. All right, back to muscle. And what we're talking about is smooth muscle in the bronchial tube. Smooth muscle is controlled by the autonomic nervous system. Skeletal muscle, you know, our ability to move our eyes, talk, swallow, move our hands, walk, sit up, right? That's skeletal muscle. That's all under conscious control. It's coming from the brain and the spinal cord. Smooth muscle is a little bit different now. That's under the control of the autonomic nervous system. Two components of the autonomic nervous system, the sympathetic side and the parasympathetic side. You remember me talking about that, particularly the fight or flight crisis when we were talking about the adrenal medulla. So it's the sympathetic and a nervous system, sympathetic and parasympathetic nervous system, which is going to control the caliber of the bronchial tubes. On the bronchial tubes are receptors referred to as beta 2. They respond to our endogenous epinephrine. Epinephrine on a beta 2 receptor relaxes the smooth muscle and the bronchial tube opens up. Acetylcholine released on the parasympathetic side. When that acts on an M3 receptor, muscarinic 3 receptor, that constricts the bronchial tube, narrowing the lumen. So let's look at the bronchial tube in terms of histology. So in the middle of the bronchial tube is airspace, nothing there. Bronchial tube is lined by that ciliated epithelial cells. We're going to look a little closer at that in a minute or two here, but you remember epithelial cells, right? Underneath the epithelial cells is the circular layer of smooth muscle. You can see that kind of stained pink. It's right underneath the darker purple stained epithelium. And then on the outside of the bronchial tube is going to be all the cartilage holding it together. Again, that no real physiology going on in terms of the cartilage. All the physiology with respect to the size of the lumen is all happening with the smooth muscle. Bronchial tubes don't exchange gas, it only transports the gas. Bronchial tubes have the smooth muscle, but remember they're lined by epithelium. Underneath the epithelium is the smooth muscle, and then in there we also have cartilage and connective tissue. And here are a number of different views of bronchial tubes in terms of cadaver sections. You can identify them on the CT scan, and on the x-rays you can certainly see all their bifurcations on the endoscopy. And then on the histology, if you look, you can, so inner is the lumen, and then you've got darker purple epithelium, you've got your smooth muscle, and then you've got your paler staining cartilage on the outer portion of that. Okay? So you see all the anatomic makeup of those bronchial tubes. Little closer at the respiratory tract epithelium, you know that they are ciliated, kind of like hair cells. on the luminal end, those hair cells are there to trap particulates, dirt, debris, smoke, trap it in mucus, and then move it superiorly so we cough it out. These epithelial cells, like all other epithelial cells, lie on a basement membrane. They should not be through the basement membrane. This epithelium is stacked. You can see it's more than a single layer. You can see there's some polarity and arrangement. There's some architecture to it. Within the epithelium are goblet cells. They secrete mucus, so we are constantly secreting some mucus into the lumen. Again, that's there to trap particulates and debris so we can cough that out or swallow it. The goblet cells are secreting a watery mucus. It shouldn't be really viscous and thick. And they secrete it based on a chloride ion channel. So in the goblet cell, on the cell membrane of the goblet cell, is a chloride ion channel called the CFTR ion channel. That ion channel pumps chloride into the lumen, and then when the chloride is pumped in, water follows, and that's what gives the bronchial mucus a really watery, thin, not extremely viscous character to it. What is the name of the disease where the individual's CFTR ion channels are adversely affected? They can't secrete chloride, therefore their pulmonary secretions are very thick and viscous, and that adds to the recurrent respiratory infections that individuals with that pathology get. Do you know the name of that pathology? You certainly know it if you're in pediatrics or if you're taking care of young adults. CF, right, cystic fibrosis. So CFTR, that ion channel is adversely affected in cystic fibrosis. Okay, then finally at the end of the bronchial tree are the terminal alveoli. They're kind of like the grapes on the vine. Very thinly walled air spaces. It is the thin wall of the alveoli that allows us to do gas diffusion. So the process of ventilation gets air in and out of the lungs. The process of diffusion moves oxygen out of the alveoli into blood and carbon dioxide out of blood back into the alveoli, and then we exhale out the carbon dioxide. So there you can see a diagram of alveoli, clumped alveoli on the terminal end of a bronchial. And then you can see the histology of the alveoli where the air is, there's nothing there, right? It's just white. And then you can see those air spaces lined by this very thin alveolar membrane. Deoxygenated blood returns to the right heart. Out of the right ventricle, we have the pulmonary artery pumping blood to the lungs. So the blood coming out of the pulmonary artery is deoxygenated. Oxygen is then picked up in the alveoli, returns to the left heart via the pulmonary veins, and then out the left ventricle through the aorta to the rest of the body is oxygenated blood. All right? So the right side, the pulmonary side, is deoxygenated. The left side, the aortic arterial side, is oxygenated. And oxygenated blood is returning to the lungs via the pulmonary veins. And there you can see that interaction of artery and veins around the alveoli. So blood flow coming into the alveoli, deoxygenated, picking up the oxygen and returning that oxygenated hemoglobin back to the heart. That process of moving air in and out of the alveoli, again, is referred to as diffusion. Pathologies of the alveoli are going to markedly impair diffusion. So it's going to be difficult to move O2 and carbon dioxide, O2 into the blood, CO2 out of the blood, in individuals who have profound pathologies of the alveoli. So again, we'll be talking about a lot of different pulmonary pathologies. We're just trying to get all the anatomy and the physiology back in your head here. Let's talk about surfactant. Surfactant is a liquid substance which is secreted by the alveoli. There's a specific type of alveolar cell called a type 2 cell. That epithelial cell in the alveolar wall secretes surfactant, and that surfactant goes inside the lumen of the alveoli. And the role of surfactant is to keep your alveoli open. We're breathing in water. There's water in air, and the effect of water vapor pressure, the pressure of water vapor, can collapse the alveoli. If you collapse your alveoli, if you can't open up your alveoli, you can't exchange gases. So surfactant is extremely important in preventing alveolar collapse. In the cartoon there, you can see the difference between alveoli with and without surfactant. So in the alveolar wall now, we're going to have alveolar cells. We're going to have capillary cells. We're going to have alveolar type 2 cells making the surfactant. And we're going to have some macrophage in there as well. We're going to have some fixed white blood cells, and those macrophages are in there as well to scavenge debris and bacteria, etc., things that may not get trapped by the cilia and the mucus in the bronchial tubes and find its way into the alveoli. So we still have some immune protection down there in the alveoli by the presence of macrophage deep down in those air pockets. So what is surfactant? Surfactant's a pretty complex mixture of protein and lipid. A lot of the lipid found in surfactant is a phospholipid. So on the left side of it, you see a polar component, a charged component of an amine, a sodium, a nitrogen, amine, and phosphate. Nitrogen's positive charge, the phosphate is a negative charge. And then off of that, you see these long hydrocarbon fatty acid tails. That compound there, dipalmitoyl phosphatidylcholine, DPPC, is an important component of surfactant. It's like a detergent. It's got a polar end and a fat soluble end, and that's essentially what detergent is. And it's very important in keeping alveoli open. Also within surfactant are a number of other proteins that are important in helping form that phospholipid layer, other proteins which are important in immune regulation. So surfactant's a pretty complex mixture of protein and lipid, and that polar big lipid DPPC is one of the more important components, individual components of surfactant. Okay, breathing. We don't have to really think about breathing. We can breathe spontaneously, and that's all due to respiratory centers that we have in our brainstem. We're going to go through neuroanatomy in some detail later in the unit, but in the brainstem, in the lowest part of the brain, the brainstem, we have an area referred to as the pons, and in the pons, we have two centers, an inspiratory and an expiratory center, and they respond to changes in oxygen and carbon dioxide, and they trigger neural impulses to travel down into the spinal cord, to the phrenic nerve, and into the nerves of the intercostal muscles, and trigger us to breathe in. And then the expiratory center shuts that off shuts the impulse off, and when the impulse is shut off, elastic recoil of the chest allows us to exhale out. Okay? O2 and CO2 concentrations are detected in the carotid arteries and in the cerebrospinal fluid. That message is sent to the brainstem. Detection of O2 and CO2 is what triggers our ability to spontaneously breathe. Those respiratory centers can be adversely affected, particularly by drugs. So can you name some drugs which like to suppress these respiratory centers of the brainstem? You can, and I know that you're naming them right now, and I hope that you said opioid analgesics, right? Morphine, hydrocodone, oxycodone, all those opioid analgesics like to suppress the respiratory center. We'll get into some of that as we move on here. All right, so we talked about oxygen and carbon dioxide, exhaling or moving oxygen and carbon dioxide out of alveoli into blood and out of blood into alveoli. So can we measure these gases? Yeah, we definitely can. And those of you that have been in clinical medicine for a while, you know that you have obtained and interpreted arterial blood gases on your patients. Sometimes you can even just interpret the venous or the capillary blood gas, but very often when we want to get a blood gas, it's usually done on arterial blood, and looking at those blood gases is critical in resuscitation and in managing respiratory pathology. So when we get a blood gas, we look at the pH, which is a measure of hydrogen ion. We look at oxygen dissolved in plasma. So that O2 level that we get is the O2 in the actual fluid component of blood. We look at CO2 levels, which is the same thing. CO2 dissolved in plasma. We look at the bicarbonate, which is our buffer for hydrogen ion. And then we look at the saturation of oxygen on hemoglobin. And remember, the far majority of our oxygen in blood is saturated to hemoglobin. It's not free in plasma. All right, so there's our blood gas. Our CO2 levels, our hydrogen ion levels, and our bicarbonate level is going to control our pH. So you know this, what happens to our pH in an individual who retains CO2. Somebody who has shallow respiratory effort or impaired diffusion can't get rid of the CO2. CO2 levels build up, and what happens to the pH? It falls, right? pH falls because the hydrogen ion concentration is increasing. We call that a respiratory acidosis. So there's the normal values for pH, O2, CO2, bicarb, and saturation. If our CO2 levels rise, our pH falls, and we refer to that as respiratory acidosis. We'll look a little bit more at the respiratory parameters with respect to blood gases, and then we'll review some of blood gases again when we get into the renal unit as we talk about bicarbonate. Normal blood pH is 7.35 to 7.45. Below 7.35 acidosis, above 7.45 alkalosis. Low CO2, alkalosis. High CO2, acidosis. All right, some more analysis here. Pulse oximetry. I know that you are all using and assessing pulse oximetry. So remember, we're inhaling air, and air is 21% oxygen. That's referred to as the inspired fraction of O2. And you put somebody on oxygen, you can dial that up to varying amounts, right? You can put someone on 30% O2, 40% O2, etc. You can measure the amount of oxygenated hemoglobin in blood. You can do that with a blood gas, but an easier way to do that is non-invasively with a pulse oximeter. Oxygenated hemoglobin looks red. Deoxygenated hemoglobin has a darker purple appearance to it. So there's a different wavelength between oxygenated and deoxygenated hemoglobin, and that's what your pulse oximetry is picking up. Again, I'm not a physicist. I don't know how these things, exactly how these machines work, but, we know how to interpret them. And this is all based on wavelength of arterial, all based on wavelength of oxygenated and deoxygenated hemoglobin. We like to live and like to keep oxygenated arterial hemoglobins greater than 95%. An individual is usually okay as long as they're over 90%. Someone who's got pulmonary pathology, we may accept 90%. It's certainly we start getting below 90 and definitely below 80 and even 70 where it really becomes threatening. So on the pulse oximeter, you get two numbers. One number is the saturation of arterial hemoglobin, and the other number is the person's pulse, right? And then you got to get a good pickup of the pulse to get a good read of the oximetry. And then what's the clinical finding? So let's say we've got somebody who's got really low deoxygenated hemoglobin. What's the clinical finding that we see on them, right? So suppose this young lady's got a SAT of 70%. She would, what's the term that we use? She would look cyanotic, right? So there you can see that deoxygenated hemoglobin coming out in an individual with cyanosis. Okay, respiratory failure is inadequate gas exchange for whatever reason, right? It could be due to failed respiratory effort, or the individual may have good respiratory effort, but they might not be able to diffuse because the pathology is in the alveoli. Or it might be due to collapse of a lung. It might be due to bronchial inflammation, right? So again, we'll get into all the pathologies, but if somebody has respiratory failure, if they're not ventilating, they're not oxygenating, and they're not diffusing gas, that's going to become life-threatening very quickly, and we're going to want to intervene on that. One of the first things that we're going to want to do is get them on supplemental O2, right? Sometimes that takes care of the problem. But if they're not ventilating and their CO2 is rising, then we may need to do something to ventilate them, right? So here you've got some individuals on O2 masks. In the center, it looks like we've got an individual who's actually being ventilated, artificially ventilated. So we'll talk about that in a minute or two here. Respiratory failure is going to lead to a drop in our O2, thus our saturated O2 concentrations will drop. Remember, our cells need oxygen, and when our cells don't get oxygen, bad things happen. When we stop getting oxygen to the brain, that starts to adversely affect mental status, going to lead to agitation and coma. Rising CO2 levels, going to lead to acidosis. Remember, as CO2 levels go up, pH drops, and acidosis can also lead to altered mental status. So mental status is an important component of assessing respiratory failure. Somebody looks like they're in respiratory distress and their mental status is starting to wax and wane, you know you've got a serious problem. Other ways that we can identify respiratory failure, so we got mental status, respiratory rate, right? It's elevated or apneic. Dyspnea, increased work of breathing, using more use of the accessory muscles, and then listening for breath sounds. What do the breath sounds sound like? Are we getting air into the lungs? Does it sound nice and clear? Or are we hearing obstructions or hearing lack of breath sounds? So there's a lot of way that we can assess respiratory failure. You do that all the time in your clinical roles. Okay, that was our quick quick review of the physiology and anatomy. Now let's get into some of the pathologies, and let's begin outside of the lungs. Let's talk about the pleura. The lungs are wrapped in pleura, very thin, frictionless tissue, and there's actually two parts of the pleura, two linings of the pleura. There's the part which is adhered directly to the lungs, referred to as the visceral pleura, and then there's the outer part which rubs against the inner thoracic wall, the parietal pleura. And between the two is a potential space. There may be a very, very small amount of fluid in there, but for the most part, there's a potential space. And that visceral and parietal pleura create two frictionless surfaces that allows for nice gliding of lungs over the chest wall. A lot of different pathologies can affect the pleural space. Trauma, infectious, fluid overload, cancer. So really quickly here, let's look at some pleural pathologies. Okay, first let's talk about blunt trauma and impact to the chest. And impact to the chest can lead to rib fractures. Rib fractures can lead to asymmetric expansion of the chest, or might even impair chest wall expansion. Remember, you got to expand the chest to get air in. So individuals who suffer from multiple fractures, particularly fractures in a series, such as what you see on this x-ray here. It's a pediatric x-ray showing you numbers of rib fractures. Numbers of rib fractures can do two things. Number one, it can impair expansion of the chest, and then the trauma can actually lead to contusion, bruising, and hemorrhage on the lung itself. You can see that in the post-mortem examples, and you can see some of that on the x-ray and CT scans. So blunt trauma can lead to what's referred to as flail chest. And in those instances, ventilation and diffusion of gases are going to be impaired due to the fact that the chest can't expand and due to the fact that the lungs are now full of blood and fluid due to the hemorrhage from the contusion. So lungs, again, air should look black on an x-ray. When you see lungs looking white, that's not normal. White can be due to inflammation, it can be due to fluid, it can be due to blood, it can be due to infection. So in the setting of blunt trauma with fractures, the white lung that you see on the chest x-ray and on the CT scan, more than likely that's indicative of hemorrhage and edema, right? And you can see, just taking a look at those lungs, you can get a good idea why flail chest and significant blunt trauma to the chest can lead to some pretty significant disturbances in ventilation and diffusion. Some more x-rays. So let's see, let's look at the normal chest x-ray on the right. See how it's nice and symmetrically inflated. Look at all the ribs. Follow each and every rib and see how nice and smooth the ribs are. Now come over to the left chest. Look at the differences in symmetry of the air, and then particularly on the right side, look at how that right side of the thorax is collapsed in due to that series of rib fractures. Can you see all that? That's a nice example of flail chest. Okay, with respect to the pleura, there's a potential space between the visceral and the parietal, but things can get in there and things can now expand that potential space into big fluid accumulations, and sometimes even air can accumulate between the visceral and parietal fluid. So the accumulation of air is referred to as a pneumothorax. The accumulation of water is a pleural effusion. The accumulation of blood is a hemothorax. And the accumulation of pus is empyema. And we'll be looking at all these as we continue to move on. The problem with something accumulating in that space of the pleura is that what's accumulating is going to be under pressure. The pressure in there is going to be greater than the pressure of the lung, and it's then going to start to collapse and deflate the lung, taking away diffusion capacity, right? As you start collapsing the lung and start collapsing those alveoli, you no longer ventilate that region. When you no longer ventilate the region, you no longer diffuse gases. So 4 different types of pathologies which can occur due to accumulation of air or some type of fluid in the pleural space. And for those of you who have seen this, you know that this can very rapidly become life-threatening. What do you see happening here? Look at the right side of the picture. So that's the patient's left. You can see nice normal ribs. You can see nice air in the lung, nice clear lung. Now come over to the left side of the photo. You should be able to see the rib fractures. There's a number of rib fractures there. Now what these ribs probably did was puncture the lung, allowed air to escape. Air escaped into the pleural space. So now can you see the pneumothorax out laterally? And you can see the lung, how the lung is being collapsed and pushed in medially. That's a nice picture of multiple fractures with a pretty extensive pneumothorax and collapse of the lung. And remember, as the lung no longer inflates, as it collapses, it starts to look more dense. That density is picked up as a shadow, so the lung now starts to look white on the x-ray as opposed to black. It's no longer filled with air. And you can see the air, that black air, accumulating outside of the lung. You can actually see some air in the soft tissue as well. If you look on the outside of the rib cage, see that black air in the soft tissue? So you would feel that as crepitus, right? You felt that before. You ever feel somebody with a pneumothorax and the air is actually leaking into the chest wall and it kind of feels like Rice Krispies in there? All right, there's a pneumothorax. There's some massive pneumothorax with almost complete collapse of the lung. So symptoms of pneumothorax: chest pain, shortness of breath, abnormal vital signs, including tachycardia and hypotension, desaturation. You don't hear breath sounds on the effective side. If you percuss their lung, it sounds like a drum, very tympanic to percussion. Under tension, it can deviate the trachea, and then a severely tense pneumothorax can actually lead to cardiac collapse. And I would imagine in these x-rays here with this extensive amount of pneumothorax, I'm sure that there's some degree of marked cardiac instability in these two patients, right? All right, hemothorax. Now, rather than air accumulating in the pleura, you've got blood accumulating in the pleura. So blood is going to look like a shadow, and now you're going to see a very dense white shadow on the x-ray. Hemothorax can happen due to a number of things. Maybe the most common reasons why we see hemothorax is due to trauma, either blunt or penetrating trauma. Can be due to cancer, can also be due to infections, anticoagulation, bleeding internally. A lot of different things can lead to hemothorax. Just like accumulation of air in the pleural space can collapse the lung, accumulation of blood can also collapse the lung. And then loss of that circulating blood volume is also going to adversely affect cardiac and hemodynamic status further. So we didn't talk about chest tubes in terms of evacuating pneumothorax, but same thing, a chest tube to evacuate the pneumothorax, to evacuate the hemothorax, re-expand the lung. A chest tube also used to evacuate the air, the pneumothorax, to re-expand the lung. Right, so hemothorax. Pleural effusions is the accumulation of a watery, non-infectious fluid in the pleural space. There's a lot of different reasons why people develop pleural effusions: heart failure, kidney failure, liver failure, things like nephrotic syndrome where people have low serum proteins, cancers. So a pleural effusion is watery fluid, and an empyema is exudative, thick, infectious fluid, and that happens due to bacterial pneumonia. And fluid can be taken off. So if we have somebody who we suspect has a pleural effusion, suspected by clinical exam, suspected by x-ray, confirm it with an ultrasound, right? Use your medical imaging to confirm what you're dealing with. You can then do a procedure referred to as a thoracentesis, where a needle with a catheter is introduced through the thoracic wall, through the pleura into that potential space, and then some of that fluid can be drained off. So look at that lower picture there, and you can actually see some of that fluid coming out into the syringe. And then you can take that fluid and you can do all kinds of tests with it, right? You can look at cell counts, cultures, proteins. You can do special markers if you're looking for other inflammatory diseases or malignant diseases. You can do cytology, look at the cells. All types of analysis can then be done on that fluid to determine, is it transudative versus exudative, and then kind of helping you arrive at a diagnosis in terms of why is that fluid there in the first place. And again, just like pneumothorax and hemothorax, accumulation of fluid also going to collapse the lung and lead to cardiopulmonary instability. Sometimes a chest tube may be needed to fully drain the chest, as opposed to a small amount of fluid might be able to be taken out by a thoracentesis. Right? The thoracentesis is the needle going in, withdrawing some of the fluid, where the chest tube, a little bit more permanent, stays in there and has persistent drainage of the pleural space. Okay, here's a pleural pathology. This is mesothelioma. This is one form of primary lung cancer. Remember, when we say primary cancer, we're talking about cancer which began in the organ, right? So primary lung cancer begins in the lung. Primary lung cancer can begin in a number of regions of the lung. When it begins on the pleura, it's referred to as a mesothelioma. So those malignant cells are originating from pleural linings. And as that tumor on the pleura grows, it starts to encapsulate the lung and it restricts the expansion of the lung. So this can be lethal in terms of its direct effect on inhibiting lung expansion, and it also becomes lethal as eventually that's going to invade and erode into the lung, and some of these mesotheliomas can also invade deeper into mediastinal structures and become metastatic. Look at that gross pathology so you can see what we're looking at here. Is you can see the heart, you can see the lung, and you can see all that cancerous growth all around that lung and invading into the mediastinum and into the great vessels. And then look at the CT scan and the chest x-ray, and again you can see that white density growing all around the outer circumference of the lung. All right, so what is the most important risk factor for development of mesothelioma? You've seen this all over TV, right? It's asbestos exposure. Asbestos was widely used pre-1970s, used in the building of ships, insulating pipes, placed in ceiling tiles. Asbestos doesn't burn, it doesn't combust, so it's a really good fire retardant, just not recognized when it was so widely used, how problematic it was going to be down the road in terms of its carcinogenic potential. People can have development of mesothelioma decades and decades after they've had prolonged asbestos exposure. Presentations of mesothelioma: shortness of breath, cough, chest pain, fatigue, feeling of a heavy chest, right? We'll talk more about presentations of lung cancer as we move on here. I just wanted to bring mesothelioma in here right now because we're talking specifically about the pleura right now. Okay, let's move into pulmonary edema. What is pulmonary edema? So our alveoli should be nice and open, nice and aerated. They should be dry. They should not be collapsed. And they should be moving oxygen and CO2 very readily. What happens to the alveoli if suddenly the alveoli, rather than having air in the alveoli, now we start putting fluid in the alveoli? So a pleural effusion is accumulation of fluid in the pleural space. Pulmonary edema now is the accumulation of fluid in the alveoli, right? And that's not good for diffusion of gas, right? If you start putting in all this watery fluid inside the alveoli, the problem is going to be diffusion. So what do you think is going to happen to O2 and CO2 and saturation concentrations? That should be a pretty easy question for you to answer. Pulmonary edema can happen due to two different reasons. If the heart fails and you get impaired cardiac contractility and blood starts to back up, so if your left heart fails, blood's going to back up into your lungs. So that's cardiogenic pulmonary edema. We'll talk about that in the cardiac units. We want to talk about non-cardiogenic pulmonary edema, or edema which is happening in the lungs due to pulmonary pathology, not due to cardiac pathology. So you got a couple pages in the textbook on pulmonary edema that are pretty good. That's worth reading. Alveoli are usually dry. Some fluid gets into the alveoli, but due to lymphatic drainage, due to what's called capillary oncotic pressure, proteins in the capillary, that water gets sucked out of the alveoli fairly quickly. We're going to talk a little bit more about oncotic and hydrostatic pressure in the cardiovascular unit. But lymphatics and capillaries within the alveoli are able to suck water out and keep the alveoli fairly dry. Pulmonary edema now is the accumulation of fluid in the alveoli, and that's going to present as difficulty breathing, increased work of breathing, shortness of breath, fatigue, exercise intolerance, wet cough, heavy chest, maybe even hemoptysis. I hope many of you have heard what a wet cough sounds like. I'm quite positive a number of you have heard that distinctive cough of pulmonary edema. And when you listen to the lungs, you hear inspiratory. You might not hear breath sounds, or you hear inspiratory crackling. And again, primary causes of pulmonary edema either due to heart failure or pathology which is occurring directly on the lungs, and that pathology is resulting in spilling of fluid into the alveoli. So we'll get into heart failure. Again, cardiogenic pulmonary edema, left-sided. Heart failure results in fluid back up into lungs. We'll talk in some detail about that in a couple of weeks. Non-cardiogenic pulmonary edema, so pathology which is occurring on the lungs, leading to diffuse inflammatory responses that leads to leaking of the capillaries, increasing permeability, and then the filling up of the alveoli with fluid. Another term for this, acute respiratory distress syndrome, ARDS. Many, many, many different etiologies of non-cardiogenic pulmonary edema. Managing non-cardiogenic pulmonary edema is also going to be dependent on appropriate management of whatever is causing the underlying pathology. Severe sepsis, severe viral infection, trauma, burns, aspiration, pneumonia, inhalation of drugs and chemicals, drug overdose, radiation, thermal injury to the lungs due to inhaling smoke or heat, and pancreatitis, another cause of ARDS, right? So non-cardiogenic, meaning it's the pathology is not from the heart, coming from somewhere else. Often that pathology is directly on the lung itself, leading to inflammation, increased capillary permeability, and filling up of the lungs, filling up of the alveoli with fluid. This could be pretty aggressive and carries a pretty high mortality rate. Those of you that are working in ICUs and critical care medicine probably deal with this on a daily basis. Initially, the inflammation, capillary leak is leading to edema. Over time, that inflammatory response becomes fibrotic, and then that fibrosis can also restrict expansion of the chest, and by restricting expansion of the chest, that can lead to impaired ventilation. The edema itself leading to impaired ventilation and diffusion. Again, hypoxemia, low blood oxygen concentrations due to impaired diffusion of gases because those alveoli are full of fluid and inflammatory debris. Again, fluid looking white on the X-ray and on the CT scan, and there you can see some very profound X-ray and very profound CT scan of non-cardiogenic pulmonary edema. A couple nice figures in the textbooks on ARDS, and again, they talk about the different phases of ARDS. Again, we've talked about the acute and the chronic phases of inflammation. This is an inflammatory response, so I think you've already got that understanding of how acute inflammation, if it doesn't resolve and get better, can lead into later, more chronic stages of inflammation, and that later stage of inflammation is hallmarked by fibrosis. Okay. Now let's wrap up the second part of this video talking about respiratory tract infections and inflammation. So remember, itis refers to inflammation. Not all inflammation is infectious. Not all infectious inflammation is bacterial. I'm going to make a point about that more than a couple of times because not all respiratory tract inflammations and not all respiratory tract infections require antibiotics. So if you have inflammation anywhere along the respiratory tract, that can be due to viruses, that could be due to allergens. That's inflammatory, but again, it's bacterial infections, inflammation due to bacterial infection, which requires antibiotics. So I want to really make a plea for you guys as future clinicians to really limit your antibiotic uses in these respiratory events to people who really require the antibiotic. If it's allergic or viral by nature, there's really no need to be using antibiotics on the majority of the individuals that you're evaluating and treating. All right, so all these itises, right? Inflammation of the sinus, sinusitis, inflammation of the trachea, tracheitis, inflammation of the bronchial tubes, bronchitis, bronchiolitis, smaller bronchial tubes, bronchitis, the larger bronchial tubes, right? Alveolitis, inflammation of the alveoli, that's pneumonia. And we're going to talk about the difference between interstitial pneumonia and lobar pneumonia as we go through these infections. Again, important. A lot of these are viral, a lot of these are self-limited, and most of these are not going to require antibiotics. You got to be careful with some people, though. Preterm infants, the elderly, those with neurologic disability, those with immune suppression, individuals who already have underlying chronic pulmonary or cardiac diseases. Simple viral infections can very rapidly become life-threatening on these types of people. So you got to be careful. You got to be careful and not, oh, it's just the virus, shake it off. A lot of people, you can say that to, a lot of people will be able to shake that off, and it will be a self-limited event, but be very careful with these special high-risk populations. All right, when does an itis need antibiotics? When the itis is due to bacterial infection. And what is the hallmark clinical finding that we see as part of the bacterial inflammatory response? It's pus, right? So purulent, disgusting mucus, right? When we're seeing pus coming out of the sinuses, out of the nose, out of the eyes, in the throat, in the sputum, right? Then we got to start thinking bacteria, then we got to start thinking antibiotics. But we should not be throwing antibiotics at every single person who has a common cold or some allergic induced itis of the respiratory tract. So let's start with allergies. Allergies are a very important cause of inflammatory disorders in the respiratory tract. In terms of the respiratory tract, we're primarily talking about rhinitis, inflammation in the nasal passage, and sinusitis, actual inflammation in the sinuses themselves. Often what we see with rhinitis and sinusitis is inflammation of the lining of the eye, so allergic conjunctivitis comes with that. Skin, eyes, and nose. If your allergies are due to outdoor allergens and they only occur at certain times of the year, you have a seasonal allergy. If your allergies are occurring year-round due to some type of indoor allergen, then you have perennial allergies. Allergies vary, right? Here are some of the most common things that individuals develop allergic reactions to. So on here, I've got the most common food products responsible for allergies, and then I have some of the most common non-food products responsible for allergies. One of the most common seasonal allergens in the U.S., particularly in the Midwestern United States, is this flowering weed here called ragweed. It's part of the aster family. This is ragweed alley. Ragweed alley is right outside of my back door. Live in West Bend, Wisconsin. There's a little park that we live against, and on the opposite end of the park is some nature preserve, and they cut walking trails in there, and those walking trails are lined with ragweed. Ragweed doesn't bother me, so I go run on these trails, walk on these trails every day with the dog. Doesn't bother me at all. But if you were a ragweed sufferer and I said, hey, want to take a walk with me down Ragweed Alley, you would say, Stramsky, you are nuts. Because within a few minutes of you being in Ragweed Alley, you'd be suffering the symptoms, right? The wasp there at the top, that's what gets me. If I get repeatedly stung, I'll end up with a pretty significant allergic reaction. Now you're thinking to yourself, well, why are you getting, what do you mean significantly stung? Meaning if I get stung by 3 or more at one time, I'll get a pretty significant allergic reaction. One doesn't bother me, but I've had a couple of instances now where I've got stung multiple times and I ended up needing antihistamines and an EpiPen. But ragweed doesn't bother me. So what's the mechanism then? The mechanism of allergic reaction is an IgE-mediated type 1 hypersensitivity. The way this works really briefly, I think you've seen this in a previous class. I hope you did. You're exposed to an allergen. In this case, it's a respiratory tract allergen, which is coming through the respiratory epithelium. That allergen gets processed by macrophage, turn on beta lymphocytes, and then those beta lymphocytes respond with immunoglobulin E, IgE. That IgE antibody then attaches to mast cells, a specific type of white blood cell, a highly granulated white blood cell loaded with inflammatory mediators. The binding of IgE to that mast cell is referred to as sensitization. On subsequent exposures to the same allergens, that allergen will bind that fixed IgE, cross-linking then of the IgE molecules on the mast cell then result in destruction of the cell membrane, degranulation, and release of the inflammatory mediators, specifically histamine. And histamine is going to have a number of adverse effects. It will be a bronchial dilator, bronchial constrictor. It's going to sensitize sensory neurons. This is where you get the itching and the burning of your skin. One of its biggest effects is on the vasculature. It will make the vasculature dilate and become more permeable. And it is the dilation of the vasculature causing more blood flow and the increased permeability causing the edema, which results in tissue swelling. So the tissue swelling that you see on the mucosal surfaces, the tissue swelling that you see in the skin, that's all due to histamine, the effect of histamine on the vasculature. Histamine will cause the vasculature to dilate, increase blood flow into the region, and then histamine will cause the vasculature to be more permeable, and then fluid is going to leak into the tissue, causing the edema. All right, what is allergic rhinitis? Allergic rhinitis affects at least 20% of the U.S. population. They can have both seasonal and perennial components. The trigger is an allergen. It's some type of foreign protein. That type of foreign protein will initiate histamine responses. The primary immunoglobulin responsible for allergic inflammatory responses is IgE. Clinical manifestations of allergic rhinitis. Often the individual does not have a fever. They have stuffy nose, runny nose, sneezing, non-productive cough. The snot that they have is typically clear as opposed to purulent. They can have red, itchy, watery eyes. Swollen eyelids with dark circles around the eyes. It's usually referred to as the allergic shiner. Here you can see the adult and the child with the allergic shiner. Sore throat, facial pain, pressure, maybe some loss of taste and smell, maybe feeling fatigue, right? Classic findings of an upper respiratory tract inflammatory response. One thing that you could see both on the conjunctival mucosa and on the nasal mucosa is what's called cobblestoning. See that lumpy, bumpy mucosa? Looks like a cobblestone road. Cobblestoning is fairly indicative of allergic inflammatory responses. You may need to magnify it to see it. I find it fairly easy to see on the conjunctiva. You kind of pull somebody's eye down and you look at their eye, use the magnification of the ophthalmoscope, and it's usually pretty easy to see cobblestoning. When you see cobblestoning in the setting of clear snot, no fever, allergic shiners, you get that skin hives, that skin urticaria, then it's pretty easy to make the diagnosis of allergic inflammation. All right, so there's allergic rhinitis. And this is urticaria or hives. It's a skin manifestation of a systemic allergen. That allergen could have come through the respiratory tract, the GI tract, could have been injected into you via a wasp sting or whatever, right? Systemic manifestation of a skin manifestation of a systemic allergen happens via urticaria or hives. Swelling and edema. And again, remember, histamine's being released in these allergies. That histamine is causing blood vessels to dilate, bring in more blood, and then causes the blood vessels to leak, increase permeability. So more leaky blood vessels means red, warm, swollen areas, and that's how it manifests on the skin. Urticaria or hives. I'm sure you have all seen this many times. Okay, so if you take urticaria and add to that respiratory effects, you have an IgE-mediated hypersensitivity reaction referred to as anaphylaxis. And this is life-threatening. And the reason that this is life-threatening is it leads to occlusion of the airway. So remember what's happening here. The blood vessels are dilating and the blood vessels are getting leaky. So dilation of blood vessels and leakiness, edema into the airway, into the mouth, lips, tongue, oral pharynx will lead to airway occlusion. Dilation of the blood vessels is going to lead to low blood pressure. And again, histamine, remember, histamine in and of itself can be a potent bronchial constrictor. So histamine now is at the core of why an individual is swelling up, occluding their airway, losing their blood pressure due to vasodilation, and becoming extremely bronchospastic due to bronchial constriction. I'm going to blame histamine for all that. So how we treat anaphylaxis. So the most important drug for managing anaphylaxis is epinephrine. Epinephrine does two primary things in managing anaphylaxis. The most important is it constricts blood vessels, inhibits vascular permeability, and this is what results in the shrinking of edema, particularly the edema causing airway obstruction. That is epinephrine's alpha-1 effect, vasoconstriction. Epi has beta-1 effect, which increases heart rate and heart contractility. That doesn't do a whole lot for anaphylaxis, but epinephrine also has beta-2 effect, which enhances bronchial opening. And we're going to talk more about bronchial opening next week when we talk about asthma. For now, epinephrine on a beta-2 receptor opens up the bronchial airway. And then other Things that we're going to need to treat anaphylaxis will be antihistamines. We need to block the effect of histamine that happens on a receptor called H1. And then we also are going to want an anti-inflammatory steroid. And you know that we've talked about anti-inflammatory steroids. Those are drugs that are glucocorticoids, act like cortisol, and we have a number of different oral or IV anti-inflammatory glucocorticoids available to us. So we covered those all back all the way to Unit 4 in endocrinology. Many antihistamines on the market. Remember, in an allergic reaction, whether it's anaphylaxis or not, histamine is activating that H1 receptor. That H1 receptor is found primarily in the vasculature, and we want to do something to inhibit that H1 receptor. H1 activation is what accounts for the respiratory, the skin, and the vascular manifestations of allergies. Then we have all types of antihistamine meds, most of them that we take orally and we put into systemic circulation. Sometimes when we just have a localized allergic response in the conjunctiva, there's topical ophthalmic antihistamine drops that we can use. So next time you're walking through Walgreens or CVS, take a look at all those different antihistamines. I'm not going to get into all these in this course, save that for pharmacology, but characteristic of all these antihistamine drugs is they are blocking the effect of histamine on the H1 receptor, and that's what's going to reverse the respiratory, skin, and vascular manifestations of allergy. Viral rhinitis now is due to viral infection. We refer to this as the common cold. Rhinoviruses, coronaviruses, adenoviruses, some of the three most common viral species responsible for the common cold. You know the clinical symptoms, right? Fever, cough, runny nose, myalgia, sore throat, headache, chills, eye discharge, can last as long as 7 to 10 days. Transmitting the common cold via airborne droplets. Take a look at the guy sneezing there. Hand-to-hand contact with the virus, hand-to-surface contact with the virus. Remember, somebody who sneezes on something, clothing, table, computer, keyboard, whatever, can have that virus on there for stay active for a period of time before it desiccates and dries out. Touch it with your hand, touch your face, and there's your transmission. Most episodes occur in winter, but you know that cold weather in and of itself is not a direct cause of getting a cold. How many times did your parents yell at you when you were a kid? Put a hat on, you're going to catch a cold. My dad still yells at me when I show up at his house in the winter and don't have a jacket on or a hat on. You're going to get a cold. Dad, it's due to transmission of the virus, not due to the weather. You can't convince them. Oh well. All right. Treating a common cold, supportive care. If it truly is a viral infection, let's please avoid antibiotics. One of the reasons that we're having so much problem with antibiotic resistance is the overuse of antibiotics for viral respiratory infection. As a future clinician, you can help stop that. But how about some of the other over-the-counter stuff? Zinc tablets. Yeah, that may be protective if taken within 24 hours of the onset of symptoms. I don't think that's going to harm anyone. Vitamin C. Some people like to do high-dose vitamin C. That's probably not going to make things worse. Go ahead if you like it. Echinacea, quite honestly, there's a lot of stuff out there about echinacea products. I personally don't feel that there's ever been any real proper study that shows that echinacea is beneficial. I know some people swear by it. Before I get on an airplane, I do an echinacea drink. If it doesn't bother you and you like it, great, take it. But in terms of the real scientific literature, I don't think there's a whole lot there to really say that everybody should be using echinacea. Over-the-counter cough cold products, remember that's for symptom relief only, and over-the-counter cough cold products are not indicated under the age of 2. A common cause of the common cold is coronavirus, and I personally have found out that Corona beer actually helps me feel a little bit better when I have some of these viral infections. And whether it's coronavirus or rhinovirus, I don't know, but sometimes a nice hot tea with rum in it, maybe sometimes in the winter when you're sick, maybe that's a little bit better than a nice cold Corona. But again, medicinal use of adult beverages to help you feel a little bit better when you have some of these infections. Do you know why it's called a coronavirus? What does corona mean in Espanol? ¿Qué quiere decir corona en Espanol? It means crown. So there's a electron microscopy of the coronavirus. Can you see the crownish appearance to it? So that's how it got its name, coronavirus. Kind of cool, huh? All right, on delay. Let's move forward here. Here are the 8 common respiratory viruses: adenovirus, influenza A, influenza B, RSV, respiratory syncytial virus, corona, rhino, metapneumovirus. That one's a bitch. Metapneumovirus, boy, you get sick with metapneumovirus. That can go on for weeks and even months. And parainfluenza. And you can see which ones are which are the ones that are causes of the common cold, which one causes croup, bronchiolitis in little kids. And then you can see true influenza. True influenza is due to either influenza A or influenza B virus, but all these different viruses can cause an influenza-like illness. So this acronym ILI, influenza-like illness, is an individual who clinically looks like he or she has the flu, but when you test them for influenza A, influenza B, they're negative, meaning that their infection is due to another virus. And here are 8 of the most common respiratory viruses. We're going to get a little deeper into influenza coming up here. Can you differentiate a cold versus the flu clinically? I think you can, right? You certainly, I think when you have a cold. You feel crummy, but not too bad. And then you get some really, hit like a locomotive. You kind of know, man, this is worse. This is influenza. This is not really a cold. So influenza, common cold, both due to highly contagious transmission of respiratory viruses. Individuals with influenza typically have higher fever. They typically feel sicker. Most people with viral infections have myalgia, pain in the muscles. But if you have actual inflammation of the muscle, myositis, now your muscles are red, swollen, and tender, true inflammation, that is far more indicative of an influenza infection versus other respiratory viruses, okay? And again, they're all passed by airborne droplets, hand to hand, hand to surface. Remember, your high-risk patients, those populations where viral respiratory infections, particularly influenza, can become fairly quickly life-threatening. The extremes of age, elderly and preterm, underlying chronic and pulmonary conditions, underlying chronic neurologic conditions, those individuals are going to have much more difficulty. The real way to distinguish a cold versus a flu is to swab them and see what they test positive for, right? And a lot of ability now to do rapid influenza testing in clinics and urgent care centers, etc. I love internet memes and internet cartoons and look up the man cold. Man, there's some funny internet stuff regarding the man cold. I will tell you that when it comes to viral respiratory infections, I am not a wuss. I deal with it and my day continues on. Now and then, maybe I have gotten sick to the point that I want to spend the day in bed, but you cannot accuse me of being a wuss with the man cold. That I can guarantee you. All right, enough about me. Let's move on. You guys had some basic microbiology. I think you understand how viruses replicate. Viruses need a human host cell to replicate. They need to attach to the cell. They need to move their DNA or RNA into the host cell, copy and incorporate that into the human DNA. The human DNA then copies and expresses the viral proteins. The proteins are reassembled, and then a new virus, a newly assembled virus, can detach from the host cell and then go on to infect other cells. So viruses need to replicate in a living host cell. Now, with respect to influenza, influenza has two unique proteins. It has a H and an N protein. If you look at viruses in general structure of a virus is an outer protein, some type of lipid capsule underneath the protein, enzymes and other proteins within the structure, and then some nucleic acid, DNA or RNA. Right? So you have this capsule, you've got proteins off the capsule, and inside that virus is where you're going to have the nucleic acid. With respect to influenza, influenza has an H protein, the hemagglutinin protein. That's the protein that it attaches to the respiratory cell with. And then it has an N protein, a neuraminidase protein. I'll spell that out in a minute here. Neuraminidase protein, and that's what allows it to release the newly formed virus, to release and go on to affect other cells. There's neuraminidase spelled for you in the slide. Okay? And influenza, A and B, and there's a C influenza that we're not going to talk about. But influenza is characterized as A or B based on what type of H and N protein it expresses. So H1N1 is a specific type of influenza A. So outer proteins characterize it as A, B, or C, and then H and N characterize it as unique species of influenza virus. H1N1 is one type of influenza A virus. All right, so there quickly, there's the life cycle of a virus. Then remember, viruses are fairly specific in terms of what they attach to. The HIV virus attaches to lymphocytic cells, right? Because the receptors, the connection between HIV occurs with receptors on lymphocytic cells. Respiratory viruses attach to respiratory epithelial cells, right? GI viruses on GI epithelial cells, hepatitis viruses on liver cells, etc. So what is Tamiflu? Let's talk about Tamiflu here. Tamiflu is a neuraminidase inhibitor. Tamiflu stops newly replicated viruses from detaching from the host cell and not allowing it to go on and affect other cells. So the individual's been infected, influenza virus has attached and started replicating, but Tamiflu and other neuraminidase inhibitor drugs bind to that neuraminidase enzyme and inhibit the cleavage of that, the breakaway of that newly formed virus off the host cell, and therefore it halts viral replication. All right, classic symptoms again of viral respiratory tract infections: cough, fever, chill, sore throat, runny nose, rhinitis, muscle pain. If you see an individual with true muscle inflammation, red, swollen, edematous muscle, you can call that myositis, and they're more likely to have influenza versus the common cold. Respiratory viruses can cause associated symptoms like diarrhea, nausea, and vomiting. But remember, influenza, true flu, is a respiratory disease. Influenza tends to last longer than some of the other common respiratory viruses. Maybe an exception to that is metapneumovirus. I don't know if you're aware of this. Southeast Wisconsin, a year ago, so that was 2017, had a pretty big outbreak of metapneumovirus infections late in spring. Complications of these respiratory infections, particularly influenza, dehydration, and pneumonia. Most people who die from influenza die due to secondary bacterial pneumonia. Common sense prevention: hand hygiene, covering nose and mouth when coughing and sneezing, staying away from exposure areas, don't going out when you're sick and exposing everyone else. And then seasonal vaccination for influenza A and B. We do not have vaccinations for the other respiratory viruses, but we certainly have seasonal vaccine for A and B. Always, again, be careful with high-risk patients. And what's the difference between antibiotic prophylaxis versus antiviral treatment, specifically with Tamiflu? If you're sick and you're positive for influenza, you can be treated with Tamiflu. If you're a high-risk patient and you're trying to avoid them from obtaining influenza, you can put them on longer courses of Tamiflu in terms of prophylaxis. So Tamiflu, oseltamivir, can be used either way. Prophylaxis or treatment. Prophylaxis really indicated more for your high-risk populations. Not everybody needs to be on Tamiflu, particularly if you're a healthy young adult with no underlying pulmonary, cardiac, or neural disease, or immune suppression. Throw immune suppression into high-risk populations as well. But you already knew that, right? You knew that. Okay, move on. Okay, something you should do is go to cdc.gov, so the main website for the Center for Disease Control, and then go to the influenza site. It's always good to take a look at that. Really, really good really good information regarding influenza on the CDC website. Each year, the vaccines change. And the vaccines change based on what components they put in the vaccine. The components for the vaccine are selected typically a couple of seasons before influenza starts hitting the Western Hemisphere. So they're selected in the February before influenza begins in October, November, same year. Okay? So the World Health Organization and the Center for Disease Control is making an educated guess on what specific viruses to put in each year. And each year the seasonal vaccine is different. In 2016 to 2017, A, California, H1N1, A, Hong Kong, H3N2, B, Brisbane, and B, oh, be careful pronouncing this one. I'm going to call it Fouquet, right? There's another way that you could pronounce that one, right? Okay, nonetheless, you can see here were the four viruses, 2As and 2Bs, which were selected for that season. In each season, there's going to be different viruses that go in there. H1N1 being one of the most aggressive viruses. So in each year, H1N1 will always be a component, and the other ones vary based on patterns being picked up by World Health Organization and CDC, particularly patterns that they're noticing in Asia. Okay, a trivalent vaccine has 3 viruses in it. A quadrivalent vaccine has 4. All vaccines have 2 A's. A trivalent has 2 A's and a B. A quadrivalent has 2 A's and 2 B's. Vaccines come either attenuated or inactivated. So a live actual pathogen is not put in the vaccine. An attenuated pathogen may be put in the vaccine. Attenuated meaning it has limited ability to cause a disease. So in a healthy individual, if you get a live attenuated vaccine, and those are typically the ones that go up your nose, you inhale, you can replicate the virus and shed the virus, but a healthy individual shouldn't get sick, shouldn't get influenza. You don't give those to immune suppressed individuals because even attenuated viruses can be problematic in an immune suppressed individuals. I don't know about your own hospital's policy, but a lot of times hospitals will say, we don't want our employees getting live attenuated vaccines because you'll be shedding viruses, or they limit it and they say, hey, if you're working in the oncology units or on the transplant units, we don't want you getting the live attenuated vaccine because you might be shedding virus. So that's institution dependent. What most people get with the seasonal vaccine is what's called the inactivated virus. That's a dead pathogen, or it's a component of the dead pathogens, such as like the proteins. That does not replicate, that does not cause disease. People get injected with an inactivated flu virus, be it trivalent or quadrivalent. They will develop an immune response, try to generate antibody against that foreign protein, thus hopefully be protective when the actual influenza season begins. So you want to get your influenza vaccine ideally before cases start showing up. But you can get, as you know, you can get vaccinated even late in the season and still get some relative protection. The difference between attenuated and inactivated is attenuated can replicate, inactivated does not replicate. Can you get symptomatic? Yes. So some individuals are going to get an inactivated vaccine. They're going to develop an immune response. And you know, when you develop immune responses, sometimes you can feel that. You can get myalgic and fever. You're not getting influenza. A lot of people love to say, oh, I got the flu. As soon as I got the vaccine, I got the flu the next day. If you got an inactivated vaccine, probably what you got the next day was you're feeling the inflammatory response. You're not really getting replication and shedding of influenza virus because that does not happen with an inactivated vaccine. And as you know, there's numbers of different vaccines approved every year: Fluvirin, Fluzone, FluMist. Those are 3 of the different types of products, and then you can see how they're characterized in terms of being tri or quad, inactivated, or live. Go to the CDC site and you could look closer at the epidemiology of influenza. So when they say there's a case of influenza, they're confirming that by testing, right? The CDC collects surveillance from well over 3,000 sites across the U.S., clinics, emergency departments, hospitals. And then during the influenza season, each week they'll release what the season looks like. So this was, what we're looking here at is 2016, and you can see influenza cases typed based on being A or B or specific types of A or B. Then you can see, again, typically the high risk months tend to be December, January, February. That's when we see the real high incidence of influenza. Most common cause of mortality due to influenza is secondary bacterial pneumonia. There's at least 3,000 deaths per year, probably even more. But again, this is just reported, documented influenza. High-risk patients are the ones who are most likely to develop secondary bacterial infection and die. There's an older slide, but shows you pediatric deaths due to influenza from 2012 to 2016, kind of showing you the number of cases and showing you when in the year it occurred. But again, winter season, highly problematic for influenza in the Western Hemisphere. Antigenic drift versus antigenic shift. What's the difference? Viruses replicate and viruses mutate, so you can get different strains of the same virus. That's a little bit of alteration. That's referred to as an antigenic drift. This happens all the time. This may be why sometimes the influenza vaccine is not as effective as it should be. The virus mutated. Remember, the vaccines are being produced early in the year, being administered late in the year. If there's been some antigenic drift or minor changes in the antigenicity, you still may get some crossover immune protection, but it might not be 100% effective. Antigenic shift is the development of a whole new pathogen, and usually this occurs in 2 or more species. So avian swine influenza, a virus which affects birds, now starts to affect pigs. Virus completely changes and forms a whole new species within the pig, and then that virus is able to transmit from animals to human. That would be antigenic shift. That's a whole new pathogen. No immunization is going to protect that because very often that pathogen has not even been characterized, much less a vaccine made towards it. And when that new pathogen goes human to human, then you have a risk of global pandemic. All right, so an influenza pandemic is human to human spread of a new viral pathogen due to antigenic shift. The most recent influenza global pandemic that we had was the swine influenza pandemic of 2009-2010. And if you were in clinical medicine at that time, you remember that because emergency departments and clinics across the U.S. were out of control. Boy, did that season suck. Over 61 million cases, over 250,000 hospitalizations, well over 12,000 deaths globally, believed to have been responsible for more than 500,000 deaths. Again, that was our last pandemic. The last scare that we had a couple of years ago, 2015, was a new H7N9 Chinese avian influenza, which was going bird to human but never went human to human. So if you were in China and you were being exposed to these birds, you could have gotten sick. The fortunate thing was if you were sick, it wasn't transmitting human to human, so it didn't become a pandemic. All right, let me just back up again and just look at this whole concept of seasonal influenza vaccines. Remember, seasonal influenza vaccines are made with either 3 or 4 conjugates of influenza. 3 is a trivalent, 4 is a quadrivalent. All of them will have 2 strains of A. The tri will have 1 B, and the quad will have 2 Bs. One of the A strains is always going to be H1N1. And for the 2017-2018 seasonal vaccine, this is what the vaccine looks like. The shots, the IM ones, are inactivated. It's viral proteins that can't replicate, but individuals can develop inflammatory symptoms. The intranasal one is attenuated. The virus can replicate. It may cause a low level of clinical illness. You cannot give these attenuated vaccines to immune suppressed patients. (2017-2018), again, here you can see how influenza distributed. H3N2 was the predominant A responsible for infections in the US. Yamagata was the predominant B line responsible for infections in the US. And you can see that that B influenza persisted a little bit longer than the H3N2 in terms of going on a little further into spring. One of the reasons in this season why people were getting influenza in spring and getting influenza despite having received the vaccine was the Yamagata strain responsible for the infection was not a strain that was predicted and was not in the vaccines. So remember, there's some similarities between these strains. You can get some cross reactions, and sometimes a seasonal vaccine is not going to be as effective if the virus mutated or if a different virus is responsible. That's kind of what happened in 2017-2018 in terms of people having gotten the vaccine but getting sicker later in the season. A lot of that was due to this B Yamagata strain. And then I talked about the neuraminidase inhibitor, oseltamivir. Be aware that there's an inhaled neuraminidase inhibitor, zanamivir. That's an inhalation of a dry powder. You should not give that one to people with asthma or COPD, as it can make their wheezing worse. That's going to be a difficult one for kids. So as a pediatric doc in a pediatric emergency department, I'm not using a whole lot of zanamivir on kids, definitely using more oseltamivir, particularly now that there are oral liquid pediatric preparations for that. I have never used peramivir, but peramivir is the newest of the neuraminidase inhibitors. It's IV, one-time IV. Its indication is for an individual being hospitalized with severe documented influenza infection. I've never used that drug. I'm not sure if any of you have seen that drug or even have that drug on the formulary at your hospitals. So there, 3 neuraminidase inhibitors. Their indications are strictly for documented influenza A, influenza B infections. Respiratory syncytial virus. So this would be an example of an ILI, influenza-like illness. Respiratory infection due to a bug other than influenza A or B. This one is big time important in terms of pediatrics. Almost all kids prior to the age of 4 are going to get infected with respiratory syncytial virus, RSV. And the spectrum of illness varies from something that looks like as simple as a common cold to something that can progress to severe pneumonia. RSV almost always starts as a simple upper respiratory infection, a cold, runny nose, fever, coughing. And then it progresses down to the small terminal bronchial tubes, leading to edema, secretion, and bronchial irritation in the bronchial tubes. The most severely affected infants are those who are born preterm, and particularly preterm infants who are still under 1 year of age. Numerous hospitalizations occur every year in the winter due to RSV infection. I just dread winter working at Children's Hospital of Wisconsin because it's just one RSV case after another. We see so many of these kids in the emergency department. We try to do a good job of not admitting them, but sometimes their illness is just so significant that they have to be admitted, and our wards can fill up and be overwhelmed very quickly with babies being admitted with RSV infection. Annually, just over 3,000 fatalities in the U.S. due to RSV. So most common cause of hospitalization and infection due to, let's say this again, RSV is the respiratory pathogen which accounts for the majority of respiratory infections and respiratory infections leading to hospitalizations in pediatrics. RSV is highly contagious. It's a highly nosocomial infection, and it's, you get a bunch of babies admitted to the hospital with RSV, and then suddenly babies and other people being admitted to the hospital for other things, including elective surgeries, etc., end up getting RSV because this just spreads like wildfire. The baby's miserable for weeks, and what really makes it suck is there's really no good treatment for RSV. Babies who are desatting and requiring pulmonary support may need oxygen. Babies who can't feed because of the degree of coughing get dehydrated. They may need IV fluids. This is very much a secretory disease, so infants who need frequent suctioning may need to be admitted strictly for pulmonary toilet managing of the secretions. Babies who get apneic need positive pressure ventilation. Now and then you see caffeine and theophylline being used as respiratory stimulants for babies who get apneic as a result of RSV. Albuterol used to be big for managing bronchospasm but RSV, but many studies have found the inefficiency and lack of effect due to albuterol in babies admitted with RSV. So we've seen a very marked reduction in albuterol use in these babies with RSV infections. Synagis, indicated for infants under the age of 1, particularly high-risk infants, preterm infants, infants with underlying chronic pulmonary or neurologic disease, may get injections of Synagis once a month over the course of the winter. Synagis is an antibody to one of the fusion proteins of RSV. So remember, influenza uses the H-hemagglutinin protein to attach to a respiratory cell. RSV uses a different type of fusion protein to attach to respiratory cells. This is an antibody against that protein. Doesn't prevent infection, but it may worsen the severity of the course if infection occurred. So again, primarily indicated for high-risk infants. This is not a vaccination. This is passive immunity, because what you're giving the infant is a immunoglobulin. And remember, babies under the age of 1, particularly preterm infants, they're less able to generate antibody as would be an older child. So this is just one way of offering some type of passive protection to the infant during the high-risk winter months of RSV infection. Another common pediatric infection is croup, or viral laryngitis. That is primarily due to parainfluenza. That virus also begins as a cold, but then where RSV will settle in the terminal bronchial tubes, this one likes to settle in the larynx, causing laryngeal edema. And infants get this characteristic inspiratory stridor. You kind of hear that when they're breathing in, and they get a very characteristic seal-like barking cough. Very often this is another self-limited benign infection. Putting a child in steamed mist shower, cold air, a lot of times resolves a little bit of that laryngeal spasm that causes them to go into that seal-like barking cough and stridor. Sometimes it leads to full outright respiratory occlusion where the individual needs to be intubated. It kind of all depends. I've seen it go both ways. Most kids do fine and are able to be managed ambulatory. Very important in the management of croup is a oral glucocorticoid anti-inflammatory steroid, and we tend to use oral dexamethasone as a one-time dose, 0.6 milligrams per kilo. Helps inhibit laryngeal edema, laryngeal inflammation, so the child can breathe comfortably through their croup, through their 2 to 3, 4 day croup infection. Croup is primarily problematic under the age of 7. Rare to see croup over the age of 8. And almost always they respond very nice to one dose of oral Decadron dexamethasone. Inhaled epinephrine sometimes helps. Epinephrine, remember, is a vasoconstrictor. So it will reduce edema. So a child with really significant respiratory distress, really significant inspiratory stridor may improve with some aerosolized epinephrine. Helium oxygen. Really bad kids will put on helium and oxygen. The mixture of helium oxygen is less dense, it's lighter, so it's easier for them to breathe. And if you want to hear something interesting, listen to a baby with croup and what their cry and what their coughing sounds like while they're on helium. You've heard people who talk, after inhaling a helium balloon. Now imagine what that continually sounds like, that baby on a helium O2 mixture. And then again, really bad croup sometimes requires inflammation. If you go on YouTube and there's all kinds of videos of people who videoed their kids and said the kids got croup, and you listen to it, at least I listen to it and say, that's not croup. I will put up a video on Blackboard that you can listen to that really is what truly is croup. When you listen to that cough, that's a seal-like barky inspiratory stridor. That's real croup, in case you've never heard it. All right, let's move on. Let's switch over to bacteria. So now respiratory tract infection due to bacteria is something where we're going to want to start pulling out the antibiotics. Here are the 3 common respiratory tract bacterial pathogens: Streptococcus pneumoniae, often referred to as pneumococcus or pneumococcal infection. It's a gram-positive diplococci, positive meaning it stains purple. Pardon me there. Stains purple. Diplococci, they live as 2 cocci, or 2 circles next to each other. Moraxella, a gram-negative diplococci, gram-negative staining red. Haemophilus influenza, non-type B, a gram-negative rod. So staining red is a negative, but rather than having a circular appearance, tends to have more of an elongated, rectangular appearance. All of these organisms can be fairly aggressive and lead to all sorts of bacterial infection along the respiratory tract. All right, bacterial sinusitis. We talked about rhinitis sinusitis with respect to viral infection. We talked about this concept of kids not developing maxillary, ethmoid, and frontal sinuses until later in life. Oh, one more time, that just drives me frickin' nuts to have a parent come in to the emergency department whose 6-month-old kid is on their 3rd or 4th course of oral antibiotics given to them by some series of practitioners, and the parent is just spazzing out, because the baby's sinusitis is not getting better. Babies don't have sinuses. Babies have nasopharyngeal airways, and that is almost always viral by nature. It doesn't need 3-4 courses of antibiotics because babies get repeated viral infections during the winter. And then the baby gets thrush, in Canada diaper dermatitis, and antibiotic-associated diarrhea. And the parents are wigging out and they're coming in to see me, and I say, the first thing that I want to tell you is your baby doesn't have sinuses and I'm going to stop the antibiotics. And then they wig out. And it's not until I get on the computer and show them pictures of infant skulls where there are no frontal sinuses and start talking about antibiotic-associated diarrhea and antibiotic-associated candidal infections that finally can start calming some of these people down and convince them to get the hell off the antibiotics and treat this like a virus. All right, off the soapbox. Can you see that I get a little perturbed at the overuse of antibiotics in babies for a common cold? Please don't do that in your future. All right, think of me, think of my emotional and mental health, because if I see that, that just drives me nuts. All right, kids, maxillary and ethmoids start to come in after 2 years of age. Frontals start to come in after 7 years of age. How are you going to distinguish bacterial sinusitis from other sinus inflammatory processes like allergic and viral? Pus, pus, and pus. Purulent stuff coming out of the sinuses, right? You can see them blowing their nose and bringing it out, or you can take a nice look up their nose past their turbinates, such as in the picture here, and see the pus balls up there. Bacterial sinusitis often comes with external sinus tenderness and erythema. Look at our two young ladies here in the picture. And then confirming that with X-ray or CT scan. All right. Bacterial sinusitis is real. Bacterial sinusitis can lead to long-term infection, can lead to osteomyelitis, can actually lead to brain abscesses. I've seen that a couple of times. But again, be careful. Most of the time you're dealing with a viral infection, and a lot of times that should not require antibiotics. Persistence of fever beyond 7 to 10 days, change in the snot from clear and runny to purulent, foul-smelling pus, external sinus swelling and tenderness, imaging evidence of sinus opacification. Now you're probably dealing with real bacterial sinusitis. And here are some nice X-rays and CT scans of opacified sinuses. The CT scan on the lower right is a adolescent I saw who had, look at that, see the maxillary all opacified, see the ethmoid opacified, and then see the big brain abscess. Bacterial sinusitis can erode through the floor of the skull and get into the parenchyma of the brain. So I'm not by any means saying bacterial sinusitis doesn't exist or that it's not threatening, because it clearly exists and it's clearly threatening. Just don't jump to sinusitis the first day somebody's got fever and a runny nose, okay? And particularly in a baby. All right, enough said about sinusitis. One more thing. Organisms again, strep pneumo, Haemophilus influenza, Moraxella catarrhalis, most common causes of acute community-acquired sinusitis. MRSA, methicillin-resistant Staphylococcus aureus, becoming more and more an important pathogen of the respiratory tract, including sinus infections. And in immune-suppressed individuals, particularly cancer patients, all sorts of different organisms, not only bacteria but also fungi, can get into the sinuses and cause very profound chronic infectious sinusitis. All right, let's get out of the sinuses and we're going to wrap this up and talk about pneumonia for a little bit. Inflammation of the lungs, pneumonitis. Now, let's be careful in some of the terminology here and how people like to talk. Pneumonia is going to imply infection. When we're talking about pneumonia, we're talking about an infection, where pneumonitis, we usually use the term pneumonitis and reserve that for non-infectious inflammation of the lung. Toxin-mediated inflammation, allergy-mediated inflammation, autoimmune inflammation of the lung. Usually we don't call that pneumonia, we call that pneumonitis. But when we're talking about an actual pathogen in the lung causing alveolar infection, then we use this term pneumonia. We can classify pneumonia as being lobar versus interstitial. We'll show you the difference coming up here, but lobar pneumonia means infection in the alveoli. Interstitial is outside of the alveoli. And then we can classify pneumonia as being community-acquired versus nosocomial. Did we catch it outside of a healthcare institution, or did we acquire it within the healthcare institution, meaning nosocomial? Look at the normal histology on the left there. You can see the wide open alveolar air cells with the thin membrane. And now move over into the middle, and now you can see true alveolar pneumonia. The alveoli are loaded with white blood cells and infectious debris, and the alveolar membrane has gotten very thick due to edema and vascular dilation. Very, very difficult to diffuse gases in an individual with pneumonia, right? In that infected segment or segments where the alveoli, where the membranes are thick and the alveoli are loaded with debris, you're going to get minimal, if any, gas diffusion going on in there, right? Another look at pneumonia in terms of the normal histology, pointing out for you bronchi, bronchial tubes, alveoli, the capillaries within the alveoli, and then what it looks like in terms of pneumonia. And again, you just get the alveoli, the alveolar lumens just loaded with the infectious debris of white blood cells and bacteria. The thickened alveolar walls becomes extremely difficult then to diffuse gases in those infected segments. Clinical presentations of bacterial pneumonia. Tachypnea, breathing fast, tachycardia, elevated heart rate, hypoxemia. Why do you imagine that someone with pneumonia is going to have low pulse oximetry? Because the alveoli are full of debris. They can't diffuse gases. They can't oxygenate hemoglobin. But you know, somebody with mild pneumonia may have normal pulse oximetry, so don't 100% rely on it. But if you see low pulse oximetry in the setting of pneumonia, you know that you've got a pretty significant infection. You can't diffuse gas. You can't open up those alveoli, so you're going to start breathing a little bit more harder. You're going to have respiratory distress. You're going to see that by the use of accessory muscles for inspiration and expiration. The classic auscultative finding of pneumonia is rales, crackling in the segments, infected segments. And then if you do percussion, if you're good at doing percussion of the thorax, you should get a fairly dull thud in the region of pneumonia, or more tympanic drum-like in the region of the air-filled alveoli. It's a skill. I would definitely encourage you to work on that, percussing the chest and appreciating dullness versus tympany. So the most common findings are respiratory, right? But be aware that pneumonia can present so many different ways in individuals. Cough, purulent cough, the coughing up of purulent sputum. is a key in thinking that that individual may have pneumonia, and it's also helpful diagnostically. And then you can take that sputum and you send that to the lab, and you can get gram stains and cultures and see if you're identifying bacteria and what bacteria, and then also what antibiotics is that bacteria sensitive and resistant to. People feel crummy with pneumonia. They get fatigue, they get muscle pain, they get joint pain in the same way that people with influenza feel crummy, right? Nausea and vomiting, abdominal pain, also common symptoms of pneumonia. I'll show you on some x-rays why some kids with pneumonia present with abdominal pain and vomiting as opposed to chest pain. We'll look at that in a second or two here. Okay, be a little careful with the terminology. This has changed and may change again. CAP, this hasn't changed. Community-acquired pneumonia, pneumonia which developed in the outpatient setting. HCAP, NHAP, and HAP, those are terms that are starting to be dropped. Now it's referred to as nosocomial pneumonia, pneumonia which has been acquired in the hospital. That usually is something that developed 48 hours after admission. So you came into the hospital without pneumonia. 2 days later, you developed pneumonia within the hospital. So that's nosocomial pneumonia, and they still use the term VAP. You develop pneumonia 48 hours after you've been intubated. So you didn't have pneumonia before you got intubated. Now 48 hours later you have it. That is referred to as VAP. I have posted a for your information only article from the New England Journal of Medicine, which is a really nice review of CAP. So if you would like, that's up on Blackboard. Feel free to take a look at that. Okay, most common bacterial organisms of pneumonia kind of depends on where it's acquired. Community acquired, CAP, versus nosocomial acquired, you got it in the hospital. Strep pneumo, Haemophilus influenza non-B, Moraxella. Again, the three most common respiratory pathogens with respect to pneumonia. Community acquired can also be due to Staphylococcus. Legionella, causing Legionnaire's disease, a specific type of bacterial pneumonia. And Mycoplasma pneumoniae, a unique organism which has a little bit different outer surface. Most bacteria have a fairly complex cell wall. Mycoplasma doesn't have a cell wall, and that's important because Mycoplasma can only be killed by antibiotics which attack proteins and not the cell wall. Most of the antibiotics that we use are cell wall inhibitory. They don't work on Mycoplasma. Nosocomial. So any CAP organism can also be acquired in a hospital, but gram-negative bugs like Pseudomonas, Klebsiella, Escherichia coli, and specifically MRSA, Staph aureus, those are far more risky in terms of nosocomial, acquiring it in the hospital versus acquiring it in the community. And how do we determine the etiologic agent? We diagnose pneumonia in an individual. How do we determine what they're sick with? Cultures and sensitivities, right? Ideally, through the obtainment of purulent sputum. So the X-ray, the CT scan will show us the infection. We make the diagnosis of pneumonia, but the findings of the X-ray or CT scan don't tell us what the organism is. Ideally, we want to isolate the organism through a gram stain in sputum, or sometimes we can isolate the organism in a blood culture as well. Sputum, right? A mixture of saliva and mucus coughed up from the respiratory tract, composed of cells, tissue, water, cellular debris, and lipids. Sputum can come a variety of different ways depending on what the pathology is. Clear and thin, thick and frothy, purulent and bloody, combinations of. You know that frothy sputum, bubbly, frothy sputum, probably more indicative of pulmonary edema. Bloody sputum, indicative more so of cancer. Purulent sputum, probably more indicative of bacterial infection. But again, it's the analysis of the sputum that's going to help us determine what's in there, particularly what infectious organisms may be in there. Don't you just love sputum? Ugh, disgusting stuff. But valuable, because you can determine a lot in terms of what pathology may be going on by just looking at what's coming up and doing some laboratory analysis of that sputum. Here's some pearls that I would throw in for you in terms of questions to ask and things to think about when you have a person that you suspect has pneumonia. So number one, always suspect pneumonia in an individual who's got a fever and a cough. Persistence of fever, purulent cough, purulent productive cough, chest pain, shortness of breath. That's starting to lock in the diagnosis for you. Listen to the lungs and hear diminished breath sounds, inspiratory crackling, dullness, percussion. A lot of times you're there, you can make a clinical diagnosis, confirm it with medical imaging, right? Think about where they got sick. Did they get sick in the community or did they get sick in the healthcare facility? They used to use this term HCAP. They changed that, healthcare associated pneumonia. Now they just call it nosocomial pneumonia, but you still may see some references to HCAP. I think nosocomial pneumonia is the better term and the more up-to-date term. They still use vapor ventilator acquired pneumonia. So if you were put on a ventilator and you didn't have pneumonia, but after being on a ventilator you acquired pneumonia, that would be ventilator acquired pneumonia. Common things are common. Know what's going on in your community. Be aware of your local public health reports. Those are readily available no matter what county you're practicing in the United States. You have access to your local public health reports and you can see what's being isolated in the community. Southeast Wisconsin does a really good job of this, particularly through the City of Milwaukee Health Department. You can get weekly notifications of what's being isolated. Look at your patient's vaccinations. A common important vaccine in pediatrics and adults right now is the pneumococcal vaccine, Pneumovax. So you got an increased risk of pneumococcal pneumonia in people who have not received that vaccine. Did they travel outside the United States? Are they immune suppressed or receiving chemotherapy? Neurologic status, underlying pulmonary history. Have they already been infected and colonized previously with an organism? And then alcoholics. Chronic alcoholism increases risks of pneumonia, and they tend to have higher susceptibility to gram-negative organisms like Klebsiella. So a lot of things that go through your head once you've arrived at that diagnosis of pneumonia to help you get closer to what might be the etiologic bug causing that pneumonia. Okay, x-rays. This isn't a radiology course, but let me tell you some stuff about x-rays. Look slowly. Look at everything. Always get lateral views. Magnify it and alter your contrast. Few people now are looking at printed x-rays on film. Almost all x-rays now are coming digital through a PAC system. Learn how to use your PAC system. Learn how to use the tools of the PAC system, particularly the magnifier, and how to alter the contrast, because you can see so much more stuff when you change the contrast and when you change the magnification. Follow the heart borders, follow the diaphragm borders, follow the mediastinum borders, look at the vasculature. When you're done looking at the lungs themselves, then look at the bones, look at the abdomen, look at the soft tissue of the neck, and then repeat and take your time. Okay? And by doing all that, you should be able to see the pathologies. Now remember, with respect to pneumonia, pneumonia is going to be accumulation of fluid and debris in the alveolar spaces. Fluid looks white on an x-ray, so you're looking for white consolidation where there should be black air. Now you're going to get better and better at recognizing pulmonary vasculatures. You're going to get better and better at recognizing the lung markings. Remember, blood's got to be going through the lungs, and you're going to see some of that as vessel density. That tends to be a little bit more central, closer to the lungs, and it gets a little bit lighter and thinner as you move out into the periphery of the lungs. But you're looking for whited segments, whited out segments as your site of pneumonia. All right, so there's some simple rules or guidelines that you can follow in looking at an x-ray. So on the big x-ray here on your right, do that. Look at that x-ray using that little guideline there, and then you should be able to see the whited out segment of pneumonia. I'll give you some more here to take a look at. So one thing that you can do now is do this and then choose two of them, go on Blackboard and tell us, you know, where do you see it? Do you see it? What side is it? What lobe would you call it? And then do you think you see a pleural effusion? Pleural effusion is fluid. Fluid tends to drop with gravity. So where you're looking for pleural effusion is at the base of the lungs. On the lateral base of the lung, you kind of get like a, you get an angle, you kind of get a sharp angle. If there's a pleural effusion, usually that angle will get blunted because fluid will tend to accumulate down in that angle first. So look at the angle of each lung at the lower lateral aspects and see if you've got a nice sharp angle or do you have something that's blunted. If you have something that's blunted, that could be indicative of a pleural effusion. All right, so there's some x-rays to look at. I want you to be aware of something called a retrocardiac infiltrate. So a retrocardiac infiltrate happens on the left and it happens behind the heart. And you got to think in 3D here. Remember, the heart is in front of the lungs. It's particularly the left lower lobe. The heart is situated in front of the left lower lobe. When you are looking at an x-ray, you want to look through the heart. So look at the heart and look through the heart. The heart should be a uniform density. If you see anything in there that looks like an exaggerated or thicker density, maybe you're looking at something behind the heart. And that's where your lateral x-ray comes into play. So you can see the heart in front and then look behind the heart, and do you see any white opacification? If you do, that's referred to as a retrocardiac infiltrate. A lot of people miss those. Always look through the heart. And these two pictures here, the AP view and the lateral view, you should be able to see the retrocardiac infiltrate on each. There they are. CT scans, just to help you out too, CT scans can find retrocardiac infiltrates a lot easier than the plain film x-ray is. Again, left side behind the heart, it's going to look opacified on a CT scan. So the upper CTs are the cross-section axial. The lower CTs on the left is your coronal behind the heart. And then your lateral, you can see the heart anterior, and then you can see your infiltrate behind it. So don't miss the retrocardiac infiltrates. We should briefly mention this again, thoracentesis, the removal of fluid from the lungs. Remember, some individuals will develop pleural effusions and actual empyema, pus accumulation in the pleural space with bacterial pneumonia. We can suspect that by listening, absence of breath sounds in the region, dullness to percussion. We can see that characteristic blunting of the angle on a chest x-ray. We can confirm that with an ultrasound. So fluid looks black on an ultrasound, so you can see the pleural effusion below the lung on the ultrasound there. And then we can set up with aseptic technique. We can do a thoracentesis, remove fluid, and then we can use that fluid to look for cell count cytology, gram stain culture, and sensitivity. Individuals who are found to have true empyema, pyothorax, or accumulation of pus in the pleural cavity, that would be a complication of a very aggressive pneumonia, or this might be a complication of a different type of thoracic abscess. There's a website you can plug into Google, and you can see some really interesting pictures of thoracic empyema. And with respect to empyema, important to get that stuff out because that is acidic, toxic debris that can be doing both acute and long-term damage to the lung and the pleura. So with respect to effusions and empyema, identify it and localize it using medical imaging. Start treating the underlying cause with IV antibiotics, pulmonary support and ventilation if required, and then evacuation of the fluid. And that evacuation can be done with a chest tube or a variety of other surgical processes, including thoracoscopy, where they're actually looking into the chest as that's being drained and adhesions being taken down, etc. Interstitial. This is pneumonia which is stringy, bilateral, shaggy. Can you see the difference between these pneumonias and the 6 pneumonias, the other ones that I gave you? Those are all lobar. The 6 that you see on the previous slide, that's lobar, localized segment. Interstitial pneumonia involves both lungs and more of a hazy, stringy pattern, and what's being infected here is the connective tissue spaces between the alveoli. This is most commonly due to viruses or that atypical bug referred to as mycoplasma. And remember, you need different type of antibiotic to take out mycoplasma. Macrolide antibiotics like azithromycin, tetracycline antibiotics like doxycycline, those work well for mycoplasma, but your general penicillin, cephalosporins, not very good for mycoplasma because penicillins and cephalosporins attack the cell wall. Mycoplasma doesn't have a cell wall. So be aware of the interstitial type x-ray. And trust me, the more you see, the more you look at, the more x-ray reports you look at, the more you have an opportunity to sit down with a radiologist or your colleagues who are NPs doing radiology, the better you will get at chest x-rays. It just takes practice. So hang in there, look at a lot of them, you'll get it. Why does lobar pneumonia cause abdominal pain? This is most common in children because if the infiltrate is on the diaphragm, very often that gets perceived as abdominal pain. And in each of these x-rays here, you see an infiltrate which is touching on the diaphragm, and very often that can be perceived as abdominal pain. Here is a Stremski pearl. Kids with fever and right-sided abdominal pain more frequently have right lower lobe pneumonia than appendicitis. Every time you see a kid with a fever and says the right abdomen hurts, do a very good pulmonary history, do a very good pulmonary exam. Because if your hearing crackles, get an x-ray, you might be dealing with pneumonia, not appendicitis. I have seen this happen many a time when an urgent care center or primary care practitioner sends a kid to the emergency department for appendicitis when what they have is a clear case of pneumonia. Be careful. Right-sided abdominal pain may be how a child presents with pneumonia. Aspiration pneumonia, won't talk much about that. You know what this is. You've seen this, I'm sure. People who have impaired swallowing mechanisms on top of compromised mental status, right? Vomit, aspirate GI, oral, and gastric contents down into the lungs. Those could be nasty, nasty, right? Head injuries, overdoses, foreign bodies, ingesting hydrocarbons, siphoning gasoline, or a young child who drinks a candle oil because they're attracted to the color or the smell of it, right? We know that individuals who are intubated on ventilators, this could be a complication of ventilator management. So again, think of it, chemicals, hydrochloric acid, vomit, infectious organisms getting down into the lungs, nasty. Why are most aspiration pneumonias on the right side? It has something to do with the anatomy. The right mainstem bronchus tends to be at a more sharper angle off the carina, so things tend to follow that way. But you certainly can see and will see aspiration pneumonia on the left as well as bilaterally. Take a look at the lower x-ray there, and clearly that is bilateral infiltrates that you're seeing. What organisms do you expect have the greatest incidence of causing infection on top of the aspiration? Very commonly, it's the oral flora anaerobes, right? I mean, anything can get in there. You can get any type of bacteria in there, but be aware that oral flora anaerobes can be a complicating component of aspiration pneumonia. Infiltrate versus atelectasis. Atelectasis is collapse of the lung. There's a lot of different reasons listed here why a lung can collapse. So again, collapse of a lung is not infiltrate in a lung, and differentiating one versus the other on an x-ray can be difficult. And that's where you're going to work with your radiologist and just kind of help you learn what's the difference between atelectasis versus infiltrate, where atelectasis is a segmental collapse and infiltrate is the development of edema and debris intraalveolar. 2 hours and 45 minutes, and we have hit the end. So pulmonary is kind of interesting, right? We took a little bit extra time at the beginning to talk about some of that anatomy and physiology. I think that's important to go through that. We're going to do a very similar thing with cardiology as well in a couple of weeks. Okay, I hope you like that. Remember, that's part 1. A lot more pulmonary stuff to talk about in Unit 2 of pulmonary, but for now, let's just focus on Unit 1. Be sure you get through your discussion boards, review the material. You got a quiz at the end of this week. That's all due next week, Tuesday. And for now, I am signing off, and I will see you this week on Blackboard. Adios.